Welcome to ALZ Talks. I'm Rebecca Edelmayer, Senior Director of Scientific Engagement with the Alzheimer's Association. Today we'll be talking about a newly approved FDA treatment. Before we begin, we want to share that this webinar is not underwritten by any individual group of companies. It is organized, arranged, and supported by the Alzheimer's Association. Of the association's total contributed revenue in 2020, 0.89% was from the biotechnology, pharmaceutical, diagnostics, and clinical research industries. Given the subject of this webinar, it is important to specifically disclose that 0.15% of total Alzheimer's Association revenue, a total of $525,000, was contributed by Biogen and Eisai in 2020. More details are available publicly at www.alz.org/transparency. Please take a moment to review the speaker's disclosures. Joining me today is Dr. Stephen Salloway. Dr. Salloway received his medical degree from Stanford Medical School and completed residencies in neurology and psychiatry at Yale University. He is the Martin M. Zucker Professor of Psychiatry and Human Behavior and Professor of Neurology at the Warren Alpert Medical School of Brown University, and Chief of Neurology and Director of the Memory and Aging Program at Butler Hospital. Dr. Salloway is an internationally recognized leader in clinical trials for the prevention and treatment of Alzheimer's disease. Dr. Salloway, thank you for joining us today to talk about a new advancement in Alzheimer's treatment. As many of you know, on June 7th, the Food and Drug Administration approved educamab. You may also hear it referred to its brand name Aduhelm, using the accelerated approval pathway. Accelerated approval allows for earlier approval of drugs that treat serious conditions and that fill an unmet medical need. Alzheimer's is a deadly disease with no survivors. Based on the review, the FDA determined that there is substantial evidence that aducanumab reduces amyloid plaques in the brain and that the reduction of these plaques is reasonably likely to predict important benefits to patients. Accelerated approval also allows the FDA to monitor treatments as they reach the market and collect additional data to verify clinical benefit. The FDA requirement that the company conduct an additional clinical trial is to verify this outcome is important and necessary. We believe this confirmatory trial should begin promptly. In today's conversation, we will address several frequently asked questions about the therapy, and by the end of the program, you will be able to describe what aducanumab is, how it is administered, and what it is designed to do. You'll be able to identify steps for accessing the treatment and identify resources available through the Alzheimer's Association. For those of you attending live, you are welcome to submit questions in the Q&A comment section. We do have people monitoring those areas to respond to you as quickly as possible. We will have time to answer a couple questions during a brief Q&A at the end of our discussion. So welcome, Dr. Steve Salloway. It's wonderful to be here with you today. I wanted to start asking a few questions that we know that we're getting a lot of questions about from the association. We have a lot of questions I want to cover, so let's first start with what is aducanumab?
Well, thanks, Rebecca and the association for including me in this important meeting, and thanks all of you for attending. Just in general, I think the approval of aducanumab, called Aduhelm, is the accelerated approval represents a turning point in the treatment of Alzheimer's, and I want to thank the thousands of study volunteers that made this possible. It's a great contribution. Aducanumab is a monoclonal antibody, so it's an immune-based treatment. It gets into the brain at low concentrations. It binds to the amyloid plaques. It stimulates the immune system to help break them up and clear them, and it lowers the amyloid plaque buildup. It's given by infusion once a month intravenously, and I think we'll get to this in a minute. It has been tested in people with early Alzheimer's disease.
So Dr. Salloway, you did mention it is an infusion. So that means that people have to see a doctor or have to go to an infusion center likely to get this type of medication, right?
Right. So this is, again, an advance for Alzheimer's. We haven't had a new treatment in 18 years, and we've never had an intravenous treatment. although certainly cancer infuses monoclonal antibodies all the time and routinely. In other areas of neurology, like multiple sclerosis, the same thing. So this is definitely doable, but it's something new. And we're going to have to work very closely with primary care. So specialists who are familiar with Alzheimer's really are going to have to rely on primary care to identify patients who might benefit and then refer them to a center where the treatment's being administered.
So, Dr. Salloway, what did we learn from the clinical trial itself?
Well, as I said earlier, the studies took place in people with early Alzheimer's, and that means mild cognitive impairment or mild dementia. They had to be building up amyloid plaques on a PET scan, on an amyloid PET scan. And we saw what the side effects were and what the potential benefits were. The medicine clearly lowers amyloid plaques. I don't think there's a great debate about that. In the phase 3 program, these are the 2 large studies that were done to confirm the earlier trial, which had some positive results. One of the trials showed a benefit in slowing down memory loss. The other did not at the higher dose. And that's what led to some of the controversy about this approval. I thought the FDA made a wise decision that because there was the lowering of amyloid plaques was not controversial, and that is a core component of Alzheimer's disease, the buildup of these plaques, and they occur early in the disease. With the potential for benefit, the FDA thought, boy, Alzheimer's is such a bad disease. I think they really listened to people who are living with Alzheimer's and family members. And they said, we want to make this treatment available because it could be of benefit and we need to study it further. I thought they really tried to find the right balance there of good science and also the best patient care. So we know that we can safely administer it. I think we'll be talking about this in a moment. There's an important side effect when you remove plaques that can occur. And we've learned how to monitor for that, and we need to continue that now that it's available for wider use. So we're recommending, I think there's Rebecca, your team hosted a great meeting on Monday for dementia experts. And I think there was a pretty good consensus that this treatment should be used for the people who are studied in the trial, people with mild cognitive impairment and mild dementia who are building up amyloid plaques, who have no contraindications for the treatment, and there are some specific things to look out for. And it's really not approved for a later stage of Alzheimer's, or not really recommended for a later stage of Alzheimer's.
And that's an important point, Dr. Salloway. This drug was only tested in those individuals. Now, it was not tested in people with more advanced cases of dementia or earlier stages of Alzheimer's disease, correct?
That's correct.
Okay.
Right. And there was no real evidence since amyloid plaques build up early and they sort of plateau, and then later in the disease, they probably play less of a role in the whole disease process. In the later stages, probably the benefit is going to be, the chance of benefit is going to be much lower in later stages of Alzheimer's.
And Dr. Salloway, can you elaborate a little bit more on, during the clinical trials, how were the investigators able to look at the amyloid in the brain? What were they using? I'm under the impression it was PET imaging and cerebrospinal fluid analysis. Can you talk a little bit about how those tools are used?
Sure. Currently, this is a big advance for our field, also being able to see the changes in amyloid. And there are 2 ways we're currently doing it. Either seeing the buildup of the amyloid plaques on a PET scan called an amyloid PET scan. That's what was used for the educamab program. You can also see the same changes in spinal fluid, where the amyloid level goes down as the plaques build up in the brain. So amyloid in the spinal fluid goes down. And we can see that when we do. It's a pretty simple test where we remove a small amount of spinal fluid and send it to the laboratory for evaluation. Now, going forward into clinical practice, we still need to verify, and we strongly recommend that that we only treat people who are building up amyloid plaques. So we need to use one of these methods, either a spinal fluid test or an amyloid PET scan. I think there will be greater availability initially for spinal fluid tests. The amyloid PET scans are available. They're not yet covered by insurers. I know those negotiations are ongoing, and we hope there will be broader coverage soon. But currently, we're going to start out with whatever amyloid test is available to patients, and so it may be spinal fluid initially. Now, another area we're working on is developing blood tests that can also see the amyloid buildup in the brain. And we're pretty close. And so we need to move quickly to get those into the clinic so that we can make this amyloid testing more widely available and cost effective.
Those are all excellent points. So I know, Dr. Salloway, you started to mention this. While this is a new treatment and it's a huge shift for the field, it's not a cure. And there are potentially also some side effects that we're seeing and identified in the clinical trials, not only with this therapeutic, but all approaches that are anti-amyloid approaches. Can you talk a little bit more about the side effects, particularly for anti-amyloid drugs?
Yeah, so one of the things we learned with all the anti-amyloid treatments that target the plaques is that when you remove them, there can be fluid shifts in the brain, and they're now referred to as amyloid-related imaging abnormalities because they show up on MRI. And for shorthand, we call them ARIA-E, means that's edema or fluid shifts, or ARIA-H, meaning hemorrhage, where there can be some leakiness of some small amount of blood products. And 70% of the time, there are no symptoms associated with this side effect. But 30% of the time, there are some kind of symptoms, usually headache, confusion, visual change, dizziness, unsteadiness. It's almost always transient. They show up on the MRI. So we used safety MRI to monitor for these, and we plan to do that in clinical practice as well. So people should know if they're considering treatment, they have to be able to have an MRI scan. They have to make sure there are no abnormalities on their initial MRI before treatment that would put them at risk of having a serious side effect. So there's a screening MRI involved. And then they have to have, we're working out the number of those MRIs, but periodic MRIs, especially during the first year. This tends to occur early with treatment. The two main risk factors for this are people who carry a specific gene called the ApoE4 gene that increases the chance of having the side effect about twice as much if you don't carry the gene, and the dose of the medicine. So we build up. Another thing we learned, to answer your earlier question, during the trials is building up on the dose gradually makes this side effect less likely and less severe. And so we will be building up, titrating the dose over a period of months now that it's available clinically.
Right, and that is something that is talked about. That word titration kind of comes up in a lot of the news that you're seeing, and that concept is, as you mentioned, increasing the dose over time to really prevent, hopefully, or reduce the risk of this type of side effect known as ARIA.
Right, we want to catch it early. It was a very manageable side effect in the trials in thousands of people. And I've seen it also in other thousands from other trials. So it can occur, it is manageable, but it requires safety monitoring. We want to make sure that providers, the people who are prescribing the drug, are aware of it and know how to monitor, and also radiologists get trained to recognize it so they can work with the providers who are prescribing the medicine to detect it early. Because again, as I said, it's usually transient and often without symptoms, but we don't want it to become more serious. And that's the reason for catching it early. And sometimes the dose needs to be adjusted until it resolves.
Those are all important points. And so Dr. Salloway, how does someone living with Alzheimer's disease find out if they're eligible to receive this new therapy? Can you maybe also even share some examples of conversations you've had with your own patients? How might you weigh this out
Sure.
and through a conversation?
Well, I think the first step is for people to talk with their doctor. So their primary care physician, if they're seeing a specialist for management of Alzheimer's as well, talk to that person too and say, gee, I heard about this treatment. And either the patient or the family member can say, do you think it might be right, for my husband or for me or whoever. And hopefully that we're going to spend some time working with the primary care and other specialists so they're aware of the criteria that we recommend for treatment, and they can help screen. So, does the person have early Alzheimer's? I think the amyloid testing will have to be done by a specialist. So if the primary care thinks they may be a good candidate, then they would refer to someone who's a dementia expert who will arrange for the amyloid testing. And if they're looking at the MRI scan, making sure that, check all the boxes that they qualify. And then the essence really of good medical practice is talking with the patient and the family about what treatment options are available. We have some oral medicines that have been around for Alzheimer's for a long time, so people should take advantage of those. This medicine doesn't replace those. Then having a very realistic discussion about this new treatment option, what it involves, coming monthly for infusions, having amyloid testing, finding out if they're building up plaques or not, having safety MRI scans and check-ins about any side effects, and then weighing out the risks of ARIA, what that side effect is, what if we know their ApoE gene status, we plan to test for that. I think it's a good idea because it does make an informed decision, helps the patient decide about their risk, and it helps the provider monitor with more care and more vigilance if they are a carrier. And so they're weighing out that the data showed some promising results, but they were not conclusive. The FDA gave accelerated approval for amyloid lowering, with a reasonable likelihood of having a slowing down of memory loss. I've seen benefit in a number of my patients who've been on this long term, but it doesn't work for everybody. There's no guarantee of benefit. And so weighing that out, what are the side effects? What are the benefits? What are the costs? And seeing if it's ultimately up to the patient and their family in deciding if it's right for them. But that conversation is really critical, and it can be more than one time. But we're having that all the time now that this treatment is available. And we're so excited to be able to have it, to tell you the truth, because I didn't know how long it would take to get to this point that we have these new treatment options. And this is just the beginning. I want people to be aware that this is the first breakthrough, and I hope of many to come. And we'll have many more conversations that we can have about treatment options in the future. But this one's available now. And I think it's important for people to weigh this out with their provider or providers and with family members and make a good decision for themselves.
Thank you, Dr. Salloway. We really appreciate you sharing all of this information. We know that early detection and accurate diagnosis has always been truly important. Approval of this new therapy really makes early detection and diagnosis even more critical, I think, based on what you said today, to ensure that individuals receive the most benefit at the earliest point possible. And we know that early detection and accurate detection is also essential because of educamab and the way it was studied in people living with early Alzheimer's dementia and mild cognitive impairment due to Alzheimer's, who showed evidence of that amyloid plaque buildup in the brain. So early and accurate diagnosis allows individuals with the disease and their caregivers to better manage medications, consider this new treatment, build a care team, manage comorbidities, receive counseling and other support services, certainly also create advanced directives and addressing driving and safety concerns that may come up. We must really continue to ensure that all individuals with Alzheimer's at every stage of the disease receive high quality comprehensive care, including access to appropriate medications. This care planning, management, and coordination, and we must ensure that caregivers get the support that they need. This drug may be a complement to comprehensive care when appropriate, but it's not a substitute for care. So as the world's largest nonprofit funder of Alzheimer's and dementia research, we understand the enormous significance of this approval. But we also need to continue to advance potential treatment avenues for diverse populations living in all stages of Alzheimer's and other dementia. We know this drug will be of great interest to many, but it is not the only important element of Alzheimer's treatment and care. The Alzheimer's Association has made it a priority to partner with healthcare systems, physicians, and CMS to ensure early and accurate diagnosis and access to appropriate treatment, care management, and care planning. This will include education of healthcare systems and physicians to ensure proper diagnosis, treatment, and care management. Even with the availability of this drug, we must ensure proper care in the present and in the future, such as helping manage multiple doctors and finding and using community support services. To ensure access, we are calling on CMS to expand the availability of dementia care services under Medicare. At this time, we do not know what insurance coverage will be for educamab. However, eliminating barriers to access is our highest priority. The Alzheimer's Association will do everything in its power to ensure access to the drug, any tests needed during the treatment process, and other associated costs for all who will benefit. Infusion therapies have been made available under Medicare and private insurance for conditions like cancer and multiple sclerosis, as Dr. Salloway mentioned. So it is reasonable to expect this for aducanumab. Finally, in addition to these commitments, the association is available to anyone who has any questions or needs support. The Alzheimer's Association 24/7 helpline is available to anyone at 1-800-272-3900. Specialists are available around the clock, 365 days a year, and can provide assistance in over 200 languages, thanks to bilingual staff and a translation service. They can help with things like learning about the symptoms of Alzheimer's and other dementias, finding local programs and services, or connecting you with your chapter. Speaking confidentially with master's level clinicians for decision-making support, crisis assistance, and education on issues families face every day. Additionally, our website, alz.org, has a wealth of information, including information about aducanumab and a wide variety of tools and resources like our Community Resource Finder, Education Center, or ALZ Connected, which is our online message board community. So Dr. Salloway, we have covered a lot of information today. I think we have time for a few questions. And so some of these common questions that we are receiving not only through the chat, but also through our helpline on a daily basis. May I take this drug with other Alzheimer's medicines or other medications or supplements?
The answer is yes. In the trials, the majority of people were taking Alzheimer's medications that prescribed orally, and so the answer is yes. And like any medicine, their care should be taken to review your medicines. Your provider should make sure that they're compatible. I think this medicine has relatively few side effects, except for the one that I mentioned, the amyloid-related imaging abnormalities. So there may be a few special conditions, but by and large, it should be compatible with most medications that people take.
Okay. So could you again, I think, confirm here, a live question we've received, is the drug only effective for those with early onset or in the early stage, I think is what they mean, of Alzheimer's? What about moderate stages or older onset?
Right, that's a great question. The data we had, the drug has only been tested in patients with early Alzheimer's. So with mild cognitive impairment and mild dementia. We don't really have data with aducanumab in later stages. We think scientifically it has a lower chance of working in later stages because amyloid plays less of a role in driving the disease process at that point. So we don't think that people in later stages are good candidates for this medicine, especially given the evidence we have at the moment.
So here's another question we received. Will this drug restore memories or cognitive function that has been lost?
That would be fantastic if it did. That's not our expectation. Our goal, we do want to work toward that over time, and I think we will be successful in restorative medicine, but not at the moment. The goal would really be slowing down the disease process to some degree, keeping people in a milder stage longer so they can function better. So we would not expect a return of function.
Okay. One question here, how is this therapy different from other medications that are currently available?
Sure. So we have 5 medicines that are approved for Alzheimer's. 4 are inhibit an enzyme that breaks down a brain chemical called acetylcholine. That's something we need for our memory and paying attention. So it makes more of that chemical available. The other, and that's approved for all stages of dementia due to Alzheimer's. The other medicine we have blocks another chemical, and it's approved for, it's an oral, both are oral types of treatment. And it's approved for moderate to severe dementia. And so this is a very different treatment. It targets a core component of the disease, the amyloid plaques, and it's our first immune-based treatment, and it's the first one given intravenously. So it's quite a bit different from the medicines we've had available up till now.
Okay. And I'm not sure if you are able to recall the number, but we have a question here about how many individuals were actually involved in the clinical trials for this drug. And I'm assuming they're referring to the phase 3 trials.
Well, my recollection, so don't hold me to this, but I was involved, so I should know exactly. But I think there were, in the phase 1 trial of educamab, there were 186 people. And then there were 2 phase 3 trials, and I think together recruited about 3,300 people.
Mm-hmm. That's a pretty large study, and that's sort of one of the reasons we see this whole drug development process is we move through sort of the size of the trials, they increase over time, and certainly the evidence builds around the safety, but also the efficacy over time.
Right. So we have quite a bit of experience in long term. I mean, we in our clinic, we've had people on aducanumab for more than 6 years. So a number of them. So we have quite a bit of experience now with continued treatment.
Okay. So I think I want to ask one last question, Dr. Salloway, because I know we'll have to sign off soon. How does someone know if they are in the mild stage and therefore a good candidate for this drug?
Okay. Well, I mean, just to give a real brief overview about Alzheimer's, I mean, we've learned a lot from many studies. And again, I want to thank the many participants who made this possible, all this information. It sounds like it's, old hat, but it's really everyday people who came forward and helped us create this knowledge base. But we know that the amyloid plaques build up in the brain, start building up 15 years before the memory loss, and then without any symptoms really associated with it. And then when the memory loss starts, another protein, the tau protein, entangles, starts to build up as well. And then the memory, unfortunately, it's a progressive disease, and memory problems and day-to-day functioning get worse as dementia progresses. And the early stages, so mild cognitive impairment, what that means is someone is having some memory trouble. So if you do a memory test, they have some difficulty, but they're still functioning pretty well. Some people may be working full-time or part-time and managing their affairs and not too much affected by the memory difficulty, even though it's present. And then in dementia or mild dementia, it's just a little bit, has progressed a little more. So they are having memory trouble and then starting to interfere day to day, and family and the person may be noticing it, and they may have more trouble working, things like that. But they're still relatively independent, having good quality of life. And when the disease advances to moderate, then people need more help. And that's when disability starts to set in. They're not as independent. They're really not able to work in any job that has a high level of demand, and or even driving safely. And so the day-to-day functioning has declined further. So this treatment is targeted at people in the early stages where there is a memory problem, but the person is still functioning pretty well.
Well, Dr. Salloway, I want to thank you for your time and expertise. Truly, we really appreciate you joining us all who have joined on the line today for this ALZ Talks. To all of you joining in this discussion, we're glad you were able to make time today for this program. As always, if you have any additional questions or are looking for resources, please don't hesitate to contact us directly at 1-800-272-3900. We have specialists that are available for you around the clock. Thank you all so much for listening today, and thank you, Dr. Salloway, again for joining us for this program.
Thanks so much.